Hello, everybody. Welcome to this session of the #HELICON conference webinar series. This is a webinar series in the project HELICON, which is financed by Belspo and coordinated by Cienzano. My name is Laura van den Borre. I'm a postdoc researcher working on the project, and I'm also joined here today by my colleagues Brigitte Vleeschouwer, who is the project coordinator. And the topic of today's session is the impact of the COVID-19 crisis on cancer care. We have three very interesting presentation lines up for you with research results for the Belgian situation. These presentations will last approximately 10 minutes each, after which we have a 5-minute Q&A session prepared. So if you have any questions, you can pose them yourself in the Q&A session, or you can also pose them via the chat box. In the meantime, I would also like to ask you to all please mute yourself. And then we will get started with this first session. The first speaker is Aude Vaandring. She's a PhD student at the UC Louvain, and she's also a quality manager at the University Hospitals of Saint-Luc. She will be presenting today very interesting research on her experiences and a survey among radiologic oncology departments in Belgium. So please, Aude, the floor is yours.
Hello, everyone. So I will try and share my presentation. So again, thank you for giving me the opportunity to share with you how COVID-19 impacted radiotherapy departments in Belgium. Indeed, we carried out a national survey during the first few months of the pandemic to try and evaluate what the impact was of that pandemic on our functioning, but also on patients we take care of on a daily basis. So I thought it was always important, and I apologize if this is already known by you, to just quickly describe to you what radiotherapy is, because radiotherapy is an important tool that we use to help cure patients of their cancers. And indeed, radiotherapy is recommended as part of treatment for more than 50% of cancer patients, be it as a treatment modality on its own, or as a complement to other treatments such as surgery, chemotherapy, immunotherapy. Radiotherapy is a local regional treatment that uses high energy ionization radiation, and it really targets the tumor volume. The treatment in itself is delivered with minimum 1 session, but it can go up to 35 sessions. So this means that the patient comes in mostly on a daily basis for more than 1 session. And so these are patients we're going to see over a few days, a few weeks, and even over a few months. The radiotherapy team itself, who are we composed of? Just so that you get a vision of it, we have radiation oncologists, which are the doctors. We have then medical physicists and medical physicist assistants that really plan the treatments. And then we have the radiation therapists, which are nurses and technologists that work at the machine and actually deliver the treatment. And then, of course, we have secretaries, engineers, psychologists that surround us and the patients. So this is just to give you a vision of what radiotherapy is. So as the pandemic came upon us, of course, we absolutely wanted to try and evaluate if there was an impact of COVID-19 on how we were working on a daily basis and especially on our patients. And this had already been initiated in other European countries. So we were really not inventing something, but we really wanted to be able to monitor it on a Belgian level. So what did we do? In Belgium, we have 26 radiotherapy departments, and we invited them all to participate in a national survey that was sent out to them, and that was initiated on March 2nd. And then resubmitted on a weekly basis so that departments could update their data. And so this would really give us a view on how time trends were being initiated in each department. Did we see changes in practice? Did we see changes in how patients were being treated? And what we really wanted to focus on was what was the COVID-19 status of staff itself, but also of patients. How did we manage patients that were either clinically suspected COVID positive patients or COVID positive patients? What was their impact on their treatment? What was the impact of COVID-19 on radiotherapy treatment themselves, where we're going to adapt the number of sessions in which the patients were going to have to come in, where we're going to adapt the treatment starts that we were initiating for patients. And then what was the impact of COVID-19 on the radiotherapy treatment itself, and that were we going to take in less patients, where we're going to adapt their fractionation schemes, that is the number of sessions that we're going to deliver to them. And as I said, we sent this survey to the 26 departments, and we were quite happy to see that even though not 100% of departments were able to participate, we had around 19 to 18 in general as a mean departments that were participating for that initial survey on March 2nd, but also on a weekly basis. So it was quite encouraging to see that departments were helping us in monitoring this COVID-19 situation. So what were the results after this 4 months of data collection? First of all, what was the COVID-19 status of staff itself? How many of our members of staffs were being tested, and how many were actually turning out to be positive for COVID-19? And what we saw quite quickly is that the number of tested staff increased over time, not necessarily because there were more COVID-19 cases in the staff, but because you could really feel that hospitals were formalizing the testing procedures within the different departments. And the element that was quite encouraging is that we saw that the positivity rate, that is the number of staff that were being tested positive, remained quite low, with the highest positivity rate being observed for the RTTs, that is the nurses and technologists working at the treatment unit. But again, it stayed for those 4 months quite low. What about our patients? What was the COVID-19 status of our patients? Again, over the 4 months, we really saw an increase of number of patients getting tested. Again, mostly due to the fact that procedures were getting formalized in hospitals, and that it became quite common that any patients that would start an oncological pathway would get systematically tested. And so we saw really the number of patients getting tested increase significantly. At the start of the data collection, we saw that there was a positivity rate of 40% of patients getting tested, but overall, over the 4 months, 15% of all radiotherapy patients got tested positive. So what did we do with those patients? How was this dealt with? So for patients that were actually tested COVID-19 positive, 32% of these patients continued their treatments without any interruptions. And when I say continued, is that the department itself adapted their procedures to take these patients in a safe manner. 20% of patients experienced treatment delays or interruptions, but these were really limited delays from 1 to 2 days, just to give department time to readapt the procedures and to eventually readapt treatments. Treatment was indeed stopped for 14% of patients, and then 6% of patients, there was no radiotherapy that was initiated. It was decided that there was no point in putting these patients in quote unquote in danger by initiating a radiotherapy treatment. And then there were other 6% of patients for which we quoted them as being requiring another intervention. In that we mean that for these patients, either unfortunately they decided to stop their radiotherapy treatment, either they were hospitalized in the intensive care unit, or unfortunately some of them did die. What about those patients that were clinically suspected COVID-19 positive patients? That is, during that period where they were being tested, what happened to those patients? 54% of patients continued their treatment without any interruptions. 28% again had a 1 to 2 day treatment interruption, the time to get the actual result of the testing. 12% of patients experienced treatment start delays, again for a few days. and 3% it was decided to not initiate radiotherapy or another intervention was required. What was the actual impact of COVID-19 on the number of radiotherapy treatments that were being delivered in our departments? Overall, here you see really a graph where we decided that March 2nd would be our baseline. That is the point where we would consider that 100% of treatment were being given. And then over time, you really see that the number of patients getting treated diminishes quite a bit to really around April 27th, we observed a 20% decrease in the number of radiotherapy treatments we were delivering. However, you really see that there are large differences between departments. Some departments really saw a decrease in number of treatments. Some even saw an increase. So you really see a variability. But in the end, at the end of the data collection period, we indeed did not observe a return to a normal situation as we maybe would have hoped. If we, and I really apologize for this busy graph, if we really cut down the numbers and we look at the number of treatments per pathology, that is the number of treatments per breast cancer, per prostate cancer, did we see any differences? And again, I apologize for the busy slide here, but what we did observe is that there were a decrease in the number of treatment starts for lung, gastrointestinal, and other types of tumors between that week of April 20th and May 18th. And from talking with the different radiation oncologists, this was really due to an accessibility of diagnostic and interventional procedures that would be required before initiating any radiotherapy or cancer treatment. And then we indeed saw later on a drop of number of treatment starts for breast cancer patients, probably due to the diminished screening procedures that were being carried out during this pandemic. So then we wondered, was there over the 2020 period a drop in the number of treatments? Were we able to catch up on those patients that maybe missed out on radiotherapy? We were able to do this in a limited way thanks to a national radiotherapy quality indicator project that exists, in which on a yearly basis we collect different quality indicators in our radiotherapy department. And one of the quality indicators we look at is the number of treatments being delivered in the different radiotherapy departments. And we saw that between 2019 and 2020, there were still quite a little bit of variability, but overall there was a difference of -3% of radiotherapy treatments per department that were observed as compared to 2019. So probably an impact of COVID-19 on a number of treatments that were being delivered. Then we quickly wanted also to look at what the impact of COVID-19 was on our radiotherapy practice. Were the same types of patients being treated, and what type of fractionation schemes we were using? Were we going to treat them in a less number of sessions, in more number of sessions? Were these being adapted? And what we quickly saw in the first few weeks of the pandemic is that 50% of departments really reported changes in radiotherapy indications. So some of the prostate cancer patients were being postponed and not immediately treated by radiotherapy. And then 70% of radiotherapy departments really changed the number of sessions that were being delivered, mostly for the prostate patients and the breast cancer patients, and this according to evidently scientifically publications. So in conclusion, for radiotherapy, there was quite a positivity rate that was observed for RTT members, that is nurses and technologists, for COVID-19, but this remained low. So staff was not highly impacted by COVID-19. For our patients, some patients were impacted by COVID-19, obviously, but 32% of these patients continued their treatment without interruptions. And 50% of the clinically suspected COVID-19 really did not experience any interruptions in the treatment. So we could go on with treating them as optimally as we could. COVID-19 unfortunately did cause a 19% decrease of national radiotherapy treatment activity during that initial period up till June 2020, with an overall decrease seemingly of 3% in number of radiotherapy treatments in 2020. And quite quickly, departments were able to reorganize themselves to adapt their indication and the fractionation schedules of radiotherapy. And they did this in a very efficient manner, which really allowed to optimize radiotherapy treatments. In that 50% of departments changed their radiotherapy indications and 70% changed really the way the treatment was going to be delivered in a most, again, optimal manner. So overall, if I can say, radiotherapy departments were really able to rapidly adapt their workflow in order to minimize the impact of COVID-19 on their departments, but on patients themselves. However, we do see that this pandemic has unfortunately still impacted the number of treatments we were able to deliver for our cancer patients. So thank you very much for giving me the opportunity to share this with you.
Thank you very much, Odd, for this. It was a very interesting presentation. Thank you for giving us some insights into the workings of the departments in Belgium. I don't know, does anybody have a question regarding this presentation? If so, please. There is a question in the chat. Do you have insights on the situation in 2021 and at the current moment?
So quantitatively, I don't have the data yet. We're doing a collection of the 2021 quality indicators, as I mentioned in my presentation. So I will only be able to give quantitative data pertaining to this. But from what I hear, there are still really departments sharing with us that the number of treatments is not as high as the previous years. But this is not because radiotherapy cannot deliver it. It's again more because patients are not probably not getting the diagnosis at the right time. I think a lot of patients do not want to go through the screening process, and so I think we're missing on quite a bit of a number of patients, but I'm sure that the speakers after me will probably share that with you too.
Okay, thank you. And maybe a question for me, do you have any plans to do a follow-up study of this survey, or?
No plans, but indeed when I was preparing the presentation, I was asking myself if I should reinitiate this, but no plans, no.
Okay. There is another question in the chat from Tine Grammans. Was it physically not too heavy for COVID-19 positives to continue treatment? Is there a difference depending on age? What do you think, Odd?
There I will answer very on a personal level, and that from what I've observed here in my own department. So I'm only talking from my department side. For most patients, it was not too heavy. They were able to combine their COVID-19 status and the radiotherapy departments. However, for those that were patients that were a little bit more sensitive, indeed, patients that were maybe a little older or patients that had more advanced cancers, often enough, this went through hospitalization and even went through the need to put into place intensive care, yes. But I don't know if it's necessarily the radiotherapy that made it worse or just the COVID-19 as itself that induced this.
Okay, thank you very much.
No problem.
Maybe the last question from Jasmine Khan. She says, thank you for this very interesting presentation. Slide 9, you show a drop in the number of treatment starts for lung cancer, GI, and other tumors. And she asks, what are the tumors involved in the category other tumors?
Other tumors was a lot of the palliative cases. So those patients that required to alleviate their pain through bone metastasis, etc. These patients, we really saw a drop of them coming in. Radiotherapy is often used to alleviate pain from bone metastasis, and during that period, we saw less of those type of patients. Most probably because their oncologist, or decided not to put them through radiotherapy, but to cover their pain more with medicine, so oral medicine. But what we did observe is a really, again, a peak after that study period in which more palliative patients came at the end of 2020. So.
Okay. Okay, thank you very much for this presentation and for answering the questions. I think it's time to move on to the second presentation with research results. And let me please introduce to you Dr. Hannah Peacock. Hannah is a data analyst working at the Belgian Cancer Registry, and today she will give a presentation on the decline and incomplete recovery in cancer diagnosis during the pandemic in Belgium. So Hannah, if you're ready, please share the screen.
Yep.
Thank you.
So today I have the honor on behalf of my colleagues at the Belgian Cancer Registry to present the results of our paper on the impact of the COVID-19 pandemic on cancer diagnoses in Belgium. Now, the paper we published covers the entire year of 2020, and thanks to the hard work of Tim Tambuizer and Petra de Nolf, I can also present updated data until the end of August 2021. So I think by now everyone is familiar with the timeline of the COVID pandemic in Belgium. In the beginning of February 2020, we had the first confirmed case of COVID-19 in Belgium. And by halfway through March, all non-essential medical services were temporarily halted, and that included the population screening programs for breast, cervix, and colorectal cancer. And these began gradually to resume from mid-May. By July of 2020, the pathology labs had reported a decrease in samples, particularly from cancer screening, and the alarm began to be raised that there could be a delay in diagnosis for cancer patients. So in order to go to work quickly on this question, we were able to get expedited deliveries from the pathology laboratories to the Belgian Cancer Registry in 2020 and 2021. And working with this raw data, we also took the 2019 raw data and treated it the same way as a comparative year. And so because we're working with raw data, we present the incidence of new invasive cancers always as a ratio of the number in 2020 or 2021 compared to the time period in 2019 to avoid some of the biases that could be introduced working with raw data. One limitation to the data I'm presenting today is that it does not yet include all of the important data we get from the hospital registrations of new invasive cancers. So we don't have information on staging and treatment at this point. The first way I'll present this data to you is in a 2-week moving average. And this compares then the time period in 2020 or 2021 versus 2019. And so what we see for the first 2 months of 2020 is that the values hover around 0% or comparable to the 2019 levels. And then when COVID-19 hits and we start to feel it in beginning of March, there's a steep decline in diagnoses below 2019 levels. And this was particularly prominent for the 80+ age group, which is shown in the dark blue line here, which drops far below the other age groups. By June 2020, this had recovered back to baseline levels, back to 2020 levels, and oscillates there until the second and third waves hit. And here again, we see, particularly in the second wave, that the impact is largely on the 80+ population, the dark blue line. But one encouraging trend we noticed just after the third wave, so around starting in April of 2021, is that this 80+ age group starts to track together with the younger age groups. And we think this may be effective the vaccine campaign, which was well underway at that time, giving some protection against delay in diagnosis for this age group. If we take this data and look at it another way over some larger time periods, again comparing the same time period in 2020 or 2021 with 2019, here we have it split out per age group with all age groups together in the first group of bars. The yellow bar gives the number of new cancer diagnoses in April of 2020 versus April of 2019. So that was the first wave of the COVID pandemic, that big drop in diagnoses that we saw. The blue bar gives the drop in diagnoses for the whole year of 2020 compared to the whole year of 2019. And then the purple bar in this first graph is the new data we've added since the publication. So this is from January 2021 until August 2021, which is actually really a snapshot out the middle of the whole COVID pandemic, because of course we're not through it yet. But this gives an idea of some of the progress of where the oscillations and the waves were at that time. So what you can see is we initially in the first wave had an overall drop of 44% in the yellow bar for all ages together. But by the end of 2020 in the blue bar, that drop was actually recovered to a 6% decline in diagnosis over all age groups together. And if we look only from January 2021 until August 2021, we see that it's comparable to the same period in 2019. But this doesn't actually mean there's a decline in diagnosis, because with the aging and growing population in Belgium, we would actually expect each year about a 1.5% increase in cancer diagnoses compared to the year prior. So here we would really expect it to be somewhat above the 2019 levels, and we're seeing that it's sitting at 0%. Now I'm going to slightly shift what's in the purple bar to cover now from beginning of January 2020 until August of 2021. So the entire time period I showed you in the 2-week moving averages, the entire time period of the pandemic in the purple bar. And you can see here that indeed the 6% decline we had in the year 2020 in the blue bar gets smaller to a 3% decline still at the remaining at the end of August 2021. So we still have some work to do to catch up the missing diagnoses and get it even to 2019 levels, let alone the levels we would predict with the increase of the aging population. Where the decline is really pronounced and remains pronounced is by the 80+ age group. So there, by the end of 2020, the decline was still 10%, and now at end of August 2021, it's only recovered 1% and is still 9% decline. But we suspect that a portion of these diagnoses will actually never be made because of the COVID mortality in this age group. So some of the patients that would have been diagnosed with cancer in 2020 or 2021 may have already passed away from COVID. I'll now split the data out by tumor sort. So again, the yellow bar gives the initial drop in the first wave of the COVID pandemic. The blue bar gives the drop during 2020 compared to 2019, and the purple bar gives the drop over the whole time period of the pandemic for which we have data from January 2020 until August 2021. And a few different cancer sorts I'd like to call out here. The first two groups of bars are non-melanoma skin cancer and melanoma, and these were the two strongest impacted in the first wave of the pandemic. They had drops of 60 and 65%. However, they're recovering nicely and continue the recovery trend into the future, and now are sitting at 4 and 5% decline in diagnosis. But for prostate cancer, lung cancer, and pancreas cancer, the diagnoses have already almost recovered to baseline, and for prostate cancer and pancreas cancer, we actually see that they're starting to creep above 2019 levels, which is what we would expect with the aging and growing population in Belgium. So this is really promising for these cancer types, that we may have rebounded in the number of diagnoses. Head and neck cancer had the largest number of largest proportion of outstanding diagnoses at the end of 2020 at 14%. And we're now seeing that this is starting to recover and is at 9%. So this is an encouraging recovery trend here, which may have to do with the extra attention that's been put on head and neck cancer, that dentists are now able to work normally again, and possibly because of a progression of the symptoms in the meantime for these patients. One concerning trend we've noticed is for kidney and bladder cancer, where the decline in diagnosis has continued and appears in the case of kidney cancer to possibly even be getting larger. So we see there a 9% decline for kidney cancer at the end of 2021 and 11% for bladder cancer. And right now it's hard to make an explanation for why these two cancers would be affected, but it's something we're going to keep an eye on moving into the future. Looking at screening cancers, here I have data till the end of 2020. And this is again a 2-week moving average for the diagnosis of female breast cancer. And then the blue line, we have all ages excluding the screening age group, and the screening age group is pulled out separately into the yellow line, and that's 50 to 69 years old. And what we can see is in the first wave of the COVID pandemic, there's an initial drop in all age groups, but the screening age group in yellow actually recovers more slowly back to baseline levels than the non-screening age group. However, by the end of 2020, the screening age group decline in diagnosis was comparable to that for the general population. For colon cancer, we had a similar effect where there was an initial decline with the first wave of the COVID pandemic, but also for colon cancer, the recovery in the screening age group took longer than in the rest of the population. But by the end of year 2020, the decline in diagnosis in the screening age group and the general population were comparable for colon cancer as well. Now we've looked at the different cancer types as groups based on the location, but of course among cancer types there can be quite some heterogeneity, and here we've split out hematological malignancies in more detail. And without going into the details of all the different types here, what you can immediately see is that the impact of the COVID-19 pandemic varied substantially just for the different entity hematological malignancies. And overall, these were actually comparable decline in diagnosis to the solid tumors, but there's a lot of heterogeneity even among different tumor types. Looking to the future, our next steps with this project is to look at the stage at diagnosis, because the first question that jumped into your mind, if there's a delay in diagnosis, is there a shift towards higher stages? We also want to look at if there was a shift in the treatment, so what the previous speaker mentioned, but also looking at if there was more use of neoadjuvant therapy, if there was a delay in time to treatment or delay between treatment modalities. And then most importantly, what was the impact on survival for the patients? Is there a compounding effect of delay in diagnosis with treatment during the pandemic? What about cancer patients who have COVID-19? And so these are some of the questions we're going to be tackling as the data become available. And with that, I'd like to thank you for your time and welcome any questions.
Thank you very much, Hannah. If you have any questions, you can raise your hand or post them via the chat box. I see we already have a question from Jasmine Khan in the chat box. She says, thank you for your very insightful presentation. For you, which cancers progress rapidly to a higher stage if not diagnosed and therefore treated timely?
Yeah, I think encouragingly, some of the more urgent to diagnose cancers like pancreas cancer saw a small decline, and it seems to already be recovering. So I think the ones with the sorts of cancers where you're going to have obvious symptoms, people are going to find their way to the doctor because it's going to be obvious symptoms and they're going to have problems. The real danger is the cancers with more symptoms that are easier to ignore for a longer period of time and that might not be diagnosed as quickly as they ought to be.
Okay, thank you. I see the time is moving so quickly, so I would suggest if anybody else has any questions for Dr. Peacock to pose them via the chat box, and then I would ask you, Hannah, to answer them there as well.
Of course.
That leaves me to our third presentation of this session with Dr. Geert Silversmith. Geert is also a member of the Belgian Cancer Registry. He specializes in cancer survival, and today he will be presenting us some work of the impact of the crisis on cancer survivors. So Geert, the floor is yours.
Thank you, Laura, for the introduction and also for the invitation to present today. Get this on. Okay, here we are. What I will show you today is an update of our publication last year on excess mortality among cancer survivors. The paper has appeared in Cancer Epidemiology, Biomarkers and Prevention. It's issue 30 and it's free access, so you can grab it and read all the details by yourself. So what's the background? Soon after the COVID crisis started, studies started to appear where they studied the cancer patients and COVID-related morbidity and mortality, and an increasing risk for these patients has been seen. These studies often focus on patients with a recent cancer diagnosis, or at least they have some active cancer treatment. And we are wondering what would be the situation among the cancer survivors. And survivor here means at least 1 year alive since diagnosis. We had two objectives for the study. One was to estimate the excess mortality in our cohort of cancer survivors. And secondly, to compare with what we would expect as an excess mortality if we use or apply the excess mortality rates from the general population. So I start off with this graph, a graph we often see in these HELICON conference series. A graph from the StatBel website showing in orange, the upper graph, the daily number of deaths in Belgium. The black line is the average daily number of deaths over the period 2009-18, and then the difference gives excess. And in red below, we have the number of COVID-19 related deaths. Now let me superimpose here the graph of the positive test, so that's a 7-day average. And we can easily identify the different COVID waves that we have had. We are now here in the 5th one. There's clearly an excess in the year 2020. And we have data from the beginning of 2020 up to March 21. And that's why we're going to focus on. We cover the first two waves and just a little bit of the third. We stick just a little bit on the general population. In the study, we have worked with the number of deaths per month. Here you see the number of deaths per year for each month. That are the lines over here. The orange line are the number of deaths in the year 2020, and 2021 is given by the average over the period 2012-19 is shown by dashed blue line. And then we easily have the excess by subtracting the value, the orange and the dashed blue. That's given in detail here on the left. So the excess simply the difference between observed. From these excess deaths, we can calculate excess rates, and they were further stratified by sex and age group. And later on, we are going to apply these rates on our cancer cohort. What about the cancer patients? Well, we focused on all patients with a new primary diagnosis in the year 2013-2018. And then we were interested in those still alive at the beginning of 2020. And we have about 240,000 cancer survivors. We're going to look at the number of deaths from the start of 2020 until the end of March 21. So for the first objective, we compare the observed number of deaths with the number we would expect if we apply the mortality that we have seen in cancer patients in the period before, and that's from 2011 to 2019. Again, from these mortality numbers, we can calculate mortality rates and apply it to our cancer survivors and take the difference. Mortality rates here were stratified on sex and age group, just like for the general population, and additionally on the attained survival time, because the conditional survival increases with survival time cancer patients. These are the results. So on top, the full line, the black one, is the total number of deaths observed per month. The dashed line is the expected number, and the difference is shown in red. That's our excess. Clearly see the first two waves. In the first wave, we had a high excess of a bit more than 400 deaths in April, and that amounts to about 35% more than we would expect. Second wave, we have the highest excess in November, also about 400, and relatively that's about almost 40% more than expected. That's for all invasive cancers together. We also had a look per cancer site, and on this slide you see the top 3 for males and females. However, when we stratify this by cancer site, the affected numbers drop, and it's a bit hard to draw strong conclusions from these graphs. But mostly we see for the different cancer sites the waves popping up. So for the second objective, we already know now that we have an excess mortality among the cancer survivors. How does this compare with what we see in the general population? Now we're going to apply our excess mortality rates for the general population to the first time that our cancer survivors generated in 2000 and 2021 until March at least. These results are given in this table. Now, the first line of the table is the full calendar year 2020. The second and the third line give you the first and the second wave COVID crisis. The first 4 columns are in fact the results that we already have seen. So these are the results generated by data on the cancer cohort alone. You can say that for the full year 2020, we have about 1,300 excess deaths. If we compare that to what we would expect with the rates from the general population, that's 1,200. The difference of about 1/3 is within the uncertainty on our estimate obtained from the cancer cohort. For the first and the second wave, this comparison is also quite similar, and from this we conclude that the excess mortality in the cancer cohort, cancer survivors, is quite similar to what we observe in the general population. I can also show you this division. So the all invasive are divided in 2 big groups. That's the solid tumors and the hematological malignancies. For the solid tumors, there's a very nice comparison between both approaches. So the estimated excess deaths and the expected excess deaths. For the hematological malignancies, it looks like what we estimate from the cancer cohort is somewhat higher than what we would expect with the rates from the general population. Again, the numbers are relatively small. So in conclusion, yes, there is an excess mortality among the cancer survivors. So with cancer survivors that are patients with a diagnosis 2013, 2018, and they're still alive at the start of 2020, we saw that, let's say, the pattern of excess mortality among the cancer survivors is not markedly different from the one observed in the general population. I would like to stress that the conclusions should not be generalized to all cancer patients, because again, we consider patients with at least 1 year since diagnosis. Please me to thank all persons involved in Belgian cancer registration, staff at our registry, and in particular my co-authors. And if there are any questions, just shoot.
Thank you, Geert. Are there any questions? If so, please raise the hand or ask them via the chat box. We have a question from Brecht de Vleeschouwer. He says, thank you, Geert. Would not we expect a disproportionality higher excess mortality in cancer patients as comorbidities are a risk factor for COVID?
We can expect that, but from what we have done, we see that among cancer survivors, the excess is not that much higher or lower than from the general population.
Okay, and I mean, it's a difficult question because we're talking about mortality, but would you think that's a good thing, that it's so comparable to the general population?
Yes, I think so.
Yeah.
It would be worse if they had a higher excess.
But then for some cancer types, there does seem to be a difference in the patterns. Some cancer types did not show an excess mortality during the second wave. So do you think there's something we might learn from these cancer types, or is that too soon?
You probably aim at these graphs?
Yeah, the colorectal and the prostate. No, the lung cancer and the breast cancer, I'm sorry.
But we are careful about these results because we find lower numbers, so the uncertainty is much bigger. Overall, we do see the two peaks, but indeed, like for breast, we don't observe the second peak. Why, we really don't know. For the others, it looks like indeed there was a little bit of excess. So we don't want to focus that much on these, but any difference there, we don't know.
Okay, thank you very much. If you have any additional questions, please ask them via the chat box to Geert. And then that leads me to present our next speaker, who will give us her closing remarks on these very interesting presentations. So please let me introduce to you Sabine Korachan. Sabine is Project Officer for Medicines and Patient Involvement in Health Research at the Belgian French-speaking Federation of Patient Organizations. So Sabine, please give us your closing remarks.
Hello everyone, and thank you, Laura, for the presentation, and thank you, of course, for this opportunity, for these small last words, actually, where I, of course, won't have any figures, but in the name of patients, of course, these figures and the attention given to all this is very important, even if a patient will never feel like an event in a database, of course. And so these closing remarks, I just want to say that they are based, of course, on testimonies collected at La Ligue des usagers de services de santé, so it has to be understood in that framework. And clearly, of course, particularly during the first wave, there has been a lot of fear and anxiety, uncertainty, and there was a lot of big havoc due to the changes in visits and consultations for all sorts of cancer patients. And regarding delayed diagnosis, we haven't collected much stress around that, but that's linked, of course, it can be linked to the fact that during that time, a patient will not always think that he or she is maybe close to a cancer diagnosis. But anyway, the strongest impact that we have collected, at least, can be resumed in one word, and it's loneliness. So most patients, of course, will understand that they are following harsh treatment and that maybe at the hospital they will have 0 visits. But upon your return back home, for example, it's very, very difficult, and also even now, so after the first wave, to have such a reduced social life, and what comes up is that it really feels like a double punishment. And during the first wave, what also comes up is that your friends, your family, your social network, sometimes also, of course, people from the institutions, such as contacts with a psychologist, it has been really, really important to support all these changes, and it's been very much appreciated. So my main message to health professionals would be, of course, to never forget that we are social animals. It's really part of our DNA as a species, and we live on the stories that we share with each other, and they are still super important, even more important with to manage your one's disease. So just to never forget that. But thank you very much.
Thank you very much, Sabine. As a data-oriented person, I want to thank you for the reminder to give some insights into the persons behind the data. So thank you very much. And that leaves me at the end of this session, and I would like to thank all of the presenters today for their insights and their very useful presentations. I hope the members of the audience will benefit from these talks today as well. I would also like to make some advertisements for the next session of this webinar. We haven't set an exact date yet, but it will be in March or April. And the topic will be data needs in times of COVID. So I think it will be a very interesting session on all people related to data researchers and data collectors and management. We have some confirmed speakers already. One of the speakers will be David Stevens, who is the chairperson of the Belgian Data Protection Authority, who will give his insights into this data needs in times of COVID. Another speaker will be Neil Hens, who is one of the main persons behind the data models we see a lot in the media on COVID-19. He will share his experiences with using different data sources to model COVID-19, as well as give some insights into what he thinks are good prospects for the future. We also have our colleagues from Cienzano working on the FiRide project, who will give us a scoop, give their first evaluations of the Belgian data research infrastructure, which are highly relevant in times of COVID-19 research. And the closing remarks will be made by Patrick Lusine, who is the head of the demography department at Stadbel. So I think it's going to be a very interesting session as well. If you're interested in joining us for this session, keep an eye out on the website or send us an email, and then we will make sure to send you an invite when we have the exact date. So thank you very much, everyone, for joining us today, and I wish you all a very good afternoon.
Thank you very much.
Thank you.